plan now is to feedback from each of the focus groups in turn, and I think we'll spend just 3 or 4 minutes, and hopefully each focus group has identified somebody who's prepared to feedback the very few key points from that focus group, and we'll see how we get on with that. So does anyone want to go first? Any of the groups?
Shall I go first and get it out of the way?
Oh, great. So I'll give you the I'll give you this microphone just so that
okay.
we can
Thank you. So I will need some help from my team, no doubt. But so we were doing translation into practice. I don't know where. Right. So just to run through very quickly, we kind of talked about the barriers to this. So first of all, talking around the disconnect between the human and the technology. So how we can overcome technical systems that don't necessarily fit with the human way of doing something. And then we talked a bit about the different terminologies and definitions, and how that's a major challenge, that people, things mean different things to different people. Then we talked a bit about, are we actually configured to learn, and that some of these conversations have been happening for 30, maybe more, 40 years, saying that the NHS is a learning organisation, but maybe we need more insight into why we are not learning. And then we talked a little bit about that healthcare is highly political, so we talked about this needing to be a long-term, to be in this for the long term, but actually if politics and governments are changing every 5 years, and it's quite difficult to do that with changing priorities and changing systems. And also we went into a bit around academic research and the funding of academic research, and how that can kind of change every 5 years, and then you move on to your searching for your next grant. So it's quite difficult to be in the long term in that respect as well. And then we talked a little bit about decision support tools as a way of translation into practice, and how we need to kind of think about the subtleties of how you deliver those. There's so many different potential decision support tools, and sometimes do we turn people off by all the different range of those, and how do you kind of minimise the disruption to people? But I don't know if you guys have got anything else to add.
Yeah, I think that we all agree that, by their own nature, learning healthcare systems represent socio-technical systems, and therefore, they require symmetry in assessing and evaluate success and failure. So we can leave, some of the things that, if there are issues around it, it's not going to be the technological one, or they're going to be technological one, but it's about, the social practice, how these systems become part of routinized practice, and how different stakeholders, different users, that's another thing that we are starting discussing. Who is the user of these systems? How different users, different stakeholders engage and embed the systems into practice. So I think that summarizes most of the discussions.
Great. Thanks a lot. That's wonderful. Anyone else? Another group want to go next?
I do training and workforce.
Great.
Actually, I'm going to get up because I can't see the picture from where I am. Okay, we had an interesting discussion. In my case, it was unencumbered by any knowledge of what the healthcare system is. But the conversation started out around obviously different people, different needs, and we know there's obviously skills going to be required in the nature of being able to ask the right question and interpret the answers coming back. But then we had a very interesting discussion about what is the nature of the system. Is it an evidence-based system, collecting data which people are very familiar with, or is it a learning system with softer, more social skills and maybe different sorts of data collected? Because that would have completely different implications for training and workforce, and in practice it's probably a mixture of both. So clearly evidence-based systems are things that sort of clinicians will be familiar with, but we might have to bring in other areas around thinking more imaginatively, thinking about when the answers don't come back as black and white, but they come back as softer answers, thinking about bias and probability and interpretation. and what that means for a new set of skills and competences. And there's issues around what the information is used for, who puts the information in, where it goes to. Quite hard to kind of resolve, because the whole concept to us was A, one we're not familiar with, and B, one that's kind of evolving anyway. So if we were to summarise the kind of top three areas, what should be called in the system, where does it go to, what is used for, what's the impact, how does that influence changing the workforce skills, we're not sure. Perhaps a whole new set of soft skills brought in, because it's about learning based rather than evidence based. And the fact that the system itself is evolving, will evolve over time, means that you've got to be capable of dealing with change. And maybe dealing with change is something that not everyone's capable, of handling all the time, because the nature of the system and how you interact with it will evolve and change over time. So maybe that's quite a big implication for workforce. I don't know if I've left anything out. I don't know if there's much of my group left actually either.
I think there was a point that we brought up as well, as you need a digital system to have a learning health system because of the scale that's required. So collecting information will be done digitally. So the person doing it is the person on the ground. Nowadays, when you write in a piece of paper, you don't have to worry about who reads it, because the only person who reads it is the person that has access to the notes. But the implication of digital information now is that it's going to be read and reproduced 1 million times for use cases that you can't even imagine.
Yeah.
So the concept of thinking that what you write may have unforeseen circumstances is might be a new concept that people might not have thought of.
Yeah.
That might, yeah.
Great, thanks
Yep,
a lot.
thank you.
That's wonderful. And our group, Sarah, is going to summarise it. I'll just bring the microphone round for you.
Yeah, thank you very much.
Thank you. Yeah. I'm not sure, but better safe than sorry.
No problem. I hope this is good enough. All right. Our discussion actually started with the very basic question, is what kind of data that we would like to improve? And the answer to that question is actually there's a large variety of the data that one would like to ideally improve for better delivery of healthcare. And alongside health, you have to think about social services as well. And then the question that follows is, what do we mean by improving the data? I mean, what we would like to do. And then we discussed about improving data in the sense that it becomes computable, that it can be actually consumed by IT systems so that it can deliver some benefit. And by all means, everybody else, please stop me when I'm wrong or correct Ed. And then the fundamental discussion was about standards that enable that kind of improvement when multiple parties agree on the way to represent information and then process it. But there was a good point about standards on what versus standards on how, because clinicians tend to get into discussions about what should be saved, what should be recorded, what should be processed, and technical people try to build standards on how to process it, how to save it, how to pass it around. And I guess the more or less discussed balance of power was that having the how as the platform and letting clinicians have an efficient iteration of a number of whats, so that if they change their minds, they should be able to do it in an efficient way without requiring the whole system, the whole infrastructure that supports that particular information gathering requirement, rebuilding from scratch. I think there's hope for UK at the moment because the government is taking a leading role in terms of setting those standards. And this is a big change from the previous attempt that cost about 8 to 10 billion pounds, where it was all left to large companies to come up with something that works, and just you have to do whatever you have to do to make it work. Instead of that, I think we now have a more collaborative approach in UK, and that approach requires a very particular type of clinician who gets involved and connects the individual technology providers, SMEs, big companies, to the teams, to the technical teams within the trusts, and finally to clinicians. And especially some characteristics of the teams in the trust and their communication with the technology providers is important, because the requirements of IT in a healthcare institution is very specific. It's hard to manage, and when people providing technological solutions, vendors, researchers, academics walk into a trust and just present something, suggest something that doesn't always fit the responsibilities or the workflow of the people working within the trust. So there needs to be someone, clinical champions, that was the term you used for it, that connects these parties and communicates critical requirements and information so that we can make it move forward. Integration with social care is also important. There are many cases where you have to think about that aspect of the actual care process and include those parties, and including them means that including them in the computation as well. So extension of just processing healthcare data and all of that into using the same capabilities in social care. That is something that deserves a bit of a thought, and I guess that's all I can remember.
I think that's fairly comprehensive. That's great.
Thank you.
Very much.
Pleasure.
So from the second set of focus groups, anyone want to? Yeah, great.
So we were talking. Thanks. We were talking about improving quality. It's this this picture here, and we talked a lot about the cycle. And I had a particular concern that I kept going on about that the loop back needs so the feeding in of the evidence back into the guideline setters, it needs to affect change at the guideline level when the information looping back needs it to change. And I think the attitude probably, or certainly at NICE, is we're the people that tell everyone else what to do, and now everyone else is going to be telling us what to do. So I think that's a shift, and is probably why I was going on about it so much. So we were talking about the convergence between data and knowledge, and we talked about governance, and whilst Tony's point about your choice of channels is well taken, surely every organisation that's doing this sort of stuff, that they want to be the best at it. So we talked about the governance around peer review. I was quite another problem I had. I was quite reassured by everyone about the big data and data warehouse and how much data NICE was going to get that we would have to handle and how we would respond to it. But apparently that's all solved and I don't have to worry about that. So. And we were having another conversation about whether these systems can help to model effects of different inputs and what the outputs are, and that was specifically around some mental health services. And I think, and we got to see one of the sort of decision models going through with us ticking boxes about are we going to give the patient this or that, and going on to the next stage. So we actually saw it live on the screen happening. That's all I can remember.
Great. It was one fair, we didn't kind of ask you to kind of report back at the end of the talk, so it's not entirely fair. But can I also sort of take responsibility in part for reassuring you about the issue of the volumes of data that
Yes.
you were concerned about.
You were the one who did it.
I was the one who reassured you particularly, and I think I should expose that because other people may feel that my reassurance was mistaken.
Oh, okay.
And
You spelt it now. Go home and
no,
worry.
let me explain. The rationale for what I was saying was that, as I see it, the management of terabytes or whatever, however many kind of huge volumes of data that people can now take is a sole technical problem and they're commodities almost to buy the equipment and the communications and that so on. What I think is unresolved but is very much pertinent to what we're talking about is what you do with the data.
Yeah.
Both in terms of the analytics and translation of the data feeding back into the process of improving guidelines.
I did realise that was my question just a bit later on.
Well, I'm not even sure that there may be people around this table who would take a more pessimistic view than I do just about the technology, and that's really I wanted to expose my assertion in case somebody wanted to correct me that managing, capturing and storing huge amounts of data is essentially, you can buy it. You can buy that capability.
Not a correction, but a bit of a comment is
Yes.
inevitable. That is, I think, one of the things that's actually hurting healthcare at the moment. The assumption that that's solved. That exists. When you just and I regularly spend time with people that run those petabytes of warehouses and process those. And the problem is, if it's how many clicks on pictures and or other very, just commercially, just today valuable information, those systems have evolved into supporting those workflow quite well. But I still think that big data in healthcare is, is far, far away from being a commodity. It is in many other fields. In finance, it is advertising, it is maybe even in genomics. But in healthcare in general, there's a great challenge ahead that for us to move the high level operational interfaces we're developing, including your work, into that engineering space. The interaction of those two is quite complicated. So I guess, just making big data work for healthcare is a challenge in its own. So
Great, thanks a lot, and I think we'll have to record that kind of the live debate about how much of a commodity it is, and I think that's a very interesting point. Okay, two groups left. You want to go next? Great. I'll give you this if you could just put it on.
Thank you.
Thank you.
So our group was the Ethics and Information Governance group. I'll stay sitting down, I think it's probably easier. So I think we started off by talking about what levels of approval might be needed depending on the level of the data. So if we were talking about linking data sets, so for instance linking primary care and secondary care data, you might need then identifiable data to do that. You might need approvals from, say, the confidential advisory group to use identifiable data without consent. And then we got into the area of, well, even if it was anonymised data that we looked at, say, within a single trust, in order to have public confidence and maintain public confidence, we might need to still get some type of consent. So we talked about whether we might have opt-in or opt-out. And I think we quite liked the idea of at least letting people opt out, so that people knew that this was going on and could have confidence. And I think in the centre there, the idea that we could be very explicit about who would see their data and who wouldn't be able to see their data. So reassuring them around the idea of, commercial companies and insurance companies, employers, for instance, might be seeing their data and being able to say, no, that won't happen. What else did we talk about? We talked about the idea that there was a huge tension between the principles and the pragmatic issues here. So we were very happy with the ideas of engagement and transparency, but not quite sure what that would mean at an individual level. And does that mean that you still have to have a 20-minute discussion with every patient that you see? Or does it mean that you can do engagement with groups, but then minimise the process of telling people that they can opt out, maybe with leaflets and telling new patients as they register that this is the system and this is what's going on. What else did we talk about? We talked about the fact that we thought it would be a process that would evolve over time, that we'd reflect on issues. Obviously, because this is a learning cycle, it means that things aren't going to be necessarily very defined up front, and that makes it quite difficult, both in terms of getting approvals, but also in terms of explaining to people how their data might be used, because it's so broad. The data sets are very broad, and the ways in which they might be used are very broad and will evolve. So that makes it quite difficult. We talked about the ethical frameworks that would need to be applied to the learning health systems, and talked about perhaps some of the untoward things that you might uncover in the process of analysing the data. So you might uncover the fact that, I don't know, a standard practice doesn't work or is actually harmful, or even individual practitioners might not be doing the best job. And so you needed to look at the ethics of all the possible implications of analysing the data. We also got into the area of, we talked about patient stories at the top there, about the power of things like patient stories and the power of textual data, and the fact that a lot of social care records would be text-based rather than sort of numeric codes, and the same in mental health, that there would be a lot of text data. And would these systems be able to cope with the richness of text data as well as just sort of straight numeric codes? Because we thought some of that information was very powerful and we didn't necessarily want to lose that. Can't think of anything else. We talked about the idea that if we were going to talk to the public about this and patients about this, that we needed to stress the idea that this was about learning and potentially also about their safety and the quality of services, so that the focus wasn't just on give us your data. It was about helping them understand how it would be used to their advantage.
That's great. Thanks a lot.
I think most of the points that we got in this particular focus group have been covered with the very rich comments that the rest of you have spoken about. This is about the technical feasibility of having a learning healthcare system. The question is, do we have all the right tools, the technical tools, and in place already to enable a learning healthcare system? And I think the general answer to it is most of the tools are in place. There's no one tool or one standard that is definitely the right one. There's a plethora of them. But there is definitely a gap in terms of how to apply the tools to a learning healthcare system. For example, you may have a very beautiful standard to describe a model of how to represent a patient digitally, but then how do you transfer that model into a working electronic health record that will scale to many, many, many patients is something that is not, that might be a skills gap there. So, and I think Brendan has tried to attempt to do this as part of his project, and there's a lot of learning, even though he has got a lot of very nice technology in place and nice tools such as the archetypes that OpenEHR provide to do it. When you come down to the nitty-gritty of actually having to do it on the ground, there's a lot of skills that are required to do that. So it was I found it quite tricky to kind of summarize everything from the focus group, but it seems to me that there are a lot of tools out there, there are a lot of standards out there that can potentially deliver this, but there's still human, it's not a commoditized thing yet. You can't just employ a company and just deliver it. There needs to be people on the ground to actually need to deliver it. And I think one thing that really take away, that learnings about what's difficult about implementing these systems need to be more widely known about, so that people don't keep repeating the same mistakes over and over again, having the misconceptions that this is a very easy thing to do, we can do it. I think that roughly summarizes. Please chip in if you think I've missed something else.
Okay, thank you. That's great. And thanks everybody for taking part today, for coming along, for giving up your time. Fergus, Greg and myself will be hanging around afterwards, so if you want to kind of keep the conversation going, then feel free to stay around and talk through any of the issues. It's been absolutely invaluable because, as we said at the start, we are not experts in any particular aspect of the learning health system, or for that matter, any of the other areas that might be affected by the learning health system, which is why we've needed all of you to come together today. And hopefully it'll have been some use to you guys as well in terms of meeting each other, meeting other people who are involved. For the next steps, what we're going to do is we're going to try and process all of this information. I wish we had some sort of technical solution for that, but unfortunately it's a bit of a bespoke problem. So we're going to process the videos and the images that have been generated through the day, and they're going to go onto the website. That'll be the first thing that happens. Then, more slowly after that, Fergus and myself are going to work through and generate synthesis, thematic analysis of each of the conversations, each of the discussions. And then we're going to try and feed that into the web page as well. And all along, the aim is to try and generate discussion among people, perhaps who were here, but mostly people who didn't have the opportunity to be here today. And then we're going to essentially evolve our final report online so that it's exposed to whoever wants to come along and look at the source data that we're using, the source evidence, look at the references that we've pulled in, and then look at our interpretation of them and comment upon that, and we'll evolve the report over the next 3 or 4 months. And so we'd be happy to have your input on all of that, and we'll try our best to keep you informed as well. If you want more frequent updates on what's appearing on the website, then you can sign up on the website. Please do that, and we'll send you updates. And please tweet about it or mention it elsewhere if you think that you can generate some interest in it. And our main objective is really to raise awareness of these issues among clinicians and among policymakers. So that's really what we're all about. And if you have any feedback about today, please feel free to grab us afterwards or email us later if you want to put some distance between yourself and us before you let us know. That would be absolutely fine as well. But just to say thank you very much, and sorry for keeping you a little bit late. It's been a really great day for us. Thanks.
Thank you.
Thank you. Could we say thank you to your brilliant artists?
Absolutely.
Most entertaining.
Thank you.